Hi friends, Namaskar. A very warm welcome to the Community Medicine November 2022 INI-CET recall session. The November 22 INI-CET was conducted in two sessions, one in the morning and another one in the afternoon or early evening, you can say. The examiners from INI-CET, they had probably taken into consideration that the topics in both the sessions should remain more or less the same kind, although the MCQ will definitely differ. For example, we had vaccine vial monitors asked in session 1, also the vaccine vial monitors in session 2. We had leprosy question in session 1, leprosy in session 2, epidemiology in session 1, epidemiology in session 2. They were more or less kind of similar. So this is what the examination was looking like in both the sessions. If you look at the chapter-wise MCQ from the total both the sessions, we can definitely see that the maximum question were from epidemiology. Next was also the communicable disease. Miscellaneous topics, of course, there were good number of questions from miscellaneous topics like disaster medicine, what is a Wood's tragedy and so on. But as expected, we had questions from epidemiology and we had questions from communicable disease. Statistics was on a lower side because stats was not very much highly asked. Stats was like what is a formula for standard deviation and what is sensitivity or specificity. That was just very simple MCQs. If you look at the topics in various chapters like vaccine, they asked both the questions on cold chain, vaccine vial monitor, communicable disease. We had two questions from leprosy. Leprosy has been talk of the town since last 2 to 3 years. Every exam has been asking questions on leprosy. Next was rabies. As expected, snake bite. I already did a session just a few days back or before the INI-CET and the exams. And we got a question from snake bite because the government of India had made a snake bite management protocol. Then as expected, we had questions from rickettsia and also from influenza. Stats, I've already discussed, it was relatively easy. Epidemiology, we had questions from attributable risk, interpretation of odds ratio, which has been asked in INI-CET in many years, many frequently asked topic. We had this new question about causal charts, scientists were there, clinical trials, MCH, contraception, concepts of community medicine, levels of prevention. These are all routine MCQs which have been asked most of the time. So let's take on and discuss some of the questions from recall. I would like to give a disclaimer first that all the questions that I'm going to discuss is not to replicate the question as it was asked in the exam. The theme is to understand the soul of the question, to understand the main crux of the topic. That what is the question that INI-CET was asking and how you should have answered it, or lessons to be learned for future upcoming exams. So question number 1, a study for smoking and lung cancer finds the attributable risk percentage for smoking as 95%. All of the following are correct explanations except you need to mark the wrong one out. 95% of the lung cancer can be avoided in smokers if smoking is eliminated. 95% of the cases of the lung cancer can be avoided in general population if smoking was eliminated. It is the fraction of people who develop disease among the exposed population. It is measured by dividing the risk difference by incidence of disease in the exposed group. So what do you think you would like to answer? The first point to understand is that attributable risk, it is given by the formula incidence in exposed minus incidence in non-exposed divided by incidence in the exposed. Attributable risk is found, it is calculated in cohort studies and gives you what? It tells you how much percentage of people will get the disease among the exposed population. If this was the total population, out of this, let us say that this is the exposed population, out of this, how many people are going to get the disease out of the exposed population? It tells you that if you take out the disease, if you take out the risk factor, how many people will not probably get the disease among the exposed. That is what is attributable risk. So if you understand this, let's go back to the MCQs and understand it again. 95% of the lung cancer can be avoided in smokers. That's the main climax of the statement. In smokers, if smoking is eliminated, this is true. That is what is the definition of attributable risk. It is the percentage of the risk factor which contributes in causing the disease. Option B, 95% of the lung cancer can be avoided in general population. Unfortunately, that is a wrong answer because in general population, when you are talking, you talk about the population attributable risk. So in general population, it is population attributable risk, and this is a false option. 95% can be avoided in general. No, it is in the smokers. It is fraction of people who develop disease among the exposed population. Option C, this is definitely correct. That is what the formula also tells you. It is measured by risk difference. What is risk difference? That is incidence in the exposed minus incidence in non-exposed. Risk difference divided by the incidence in exposed. This is also a true option. So which of the following you're going to mark? Option number B is the wrong answer. That is what is the best possible answer in this question. Next MCQ. The image shown below depicts what level of prevention? Health promotion, specific protection, primary prevention, or disability limitation? This question again has been discussed a lot of times in different video lectures in your Marrow application. It has been discussed in my book Conceptual Review of Community Medicine. It has been discussed in almost every test and discussion session that I have been taking. This is what level of prevention? Direct question. So beta, we already know that there are 4 levels of prevention: primordial prevention, primary prevention, secondary and tertiary. So in primary prevention, primary prevention, you prevent what? In primary prevention, we are going to prevent the disease. In primordial, you prevent the risk factors. In secondary, you prevent the complication, and in tertiary, you prevent the disabilities or the death. There's a very simple table or a chart which you had been seeing, I think, in almost all the lectures of mine. So if you understand this, please note that this people, what are they doing? They are doing their lower limb or feet or legs washing to keep them safe and hygienic and sanitized. So this is what level? This is kind of the complication has already occurred in lymphatic filariasis. This is elephantiasis, right? So the complication has already occurred. Now you are trying to do disability limitation, or you are preventing the further permanent disabilities because of elephantiasis or the lymphedema or whatever we might call it. So this is a perfect example of disability limitation. This is a simple chart. You must have seen it many times. This is a very frequently asked MCQ. 5-star MCQ, frequently asked question. What are different levels of prevention? Primordial prevention, health education, health promotion, lifestyle modification. Primary prevention has been asked many times: vaccines and immunization. These are also called as specific protection. What is specific protection? That is giving vaccines and immunization. Secondary prevention is early diagnosis and treatment. Tertiary prevention is rehabilitation, transplant surgeries, giving prosthesis, disability limitation. All these come under the tertiary level of prevention. So what is the best answer over here? Disability limitation. And the next is coming to question number 3. A pregnant female less than 34 weeks of gestation reports with mild to moderate anemia. What is the best management plan as per the Anemia Mukt Bharat? Please note that the Anemia Mukt Bharat, it is Anemia Mukt Bharat. It is primarily for giving free iron folic acid supplementation. It is basically a prophylactic or a preventive program. But in case a female during her ANC, during her pregnancy, she comes to the health center with anemia, she is diagnosed with anemia, then again under the Anemia Mukt Bharat program only, we are supposed to take care of the anemia as per the guidelines. So the options are 2 tablets of IFA to be given with iron sucrose injection, or 3 tablets of IFA to be given per day. IV iron sucrose if female is not tolerating, or intramuscular IM FCM, that is ferric carboxymaltose, to be given. So which of the following is correct? Please note that this is a direct question from the Anemia Mukt Bharat guideline, that what to do in case of hemoglobin less than 10, less than 7, mild, moderate or severe anemia. Please note that anemia in a pregnant female, it is categorized as, the criteria is if the hemoglobin is less than 11 gram%. From 10 to 11, it is called as mild anemia. From 7 to 10, that is 9.9 to 7, right? So less than 11 is mild anemia, 10 to 11 is mild anemia, 7 to 10 is moderate anemia, less than 7 is severe anemia. So based on this, we categorize the female, whether the female is having mild anemia, moderate or severe anemia. If you look at the female who is having mild, moderate or severe anemia, the treatment is kind of same, more or less. For your MCQ exams, you should be knowing it is kind of same for mild to moderate anemia. At mild to moderate anemia, if you look at the treatment at the community level, the health worker is supposed to give 2 tablets of iron folic acid to the female in case the female has a HB of more than 7 but less than 11. Take 2 tablets of iron folic acid, that is the prophylactic. So it is given at the ANC contact. Now after this, the health worker is supposed to do sequential follow-ups. In case there is less than, mind the language, in case there is less than 1 gram per deciliter increase of the hemoglobin, that means the female is not responding, we need to step up. Or in case the female is not able to tolerate the iron folic acid tablets, in those cases also we need to step up. What is the next step? In the next step, you can give, in case of high-risk females, non-compliant, late in pregnancy presentation, we can give IV, no intramuscular, IV iron sucrose, or we can give the IV FCM, that is ferric carboxymaltose. So that is a treatment for mild to moderate. In case of severe anemia, the severe anemia cases only have to be managed in a PHC, CHC, FRU or district hospital or anywhere, but not at the subcenter level. We are going to give IV injections, that is IV FCM, ferric carboxymaltose or IV sucrose. And depending on the need of the female, we also need to hospitalize or give blood transfusion. So severe only has to be managed at a health facility, whereas the mild to moderate can be managed at a public health or a community level or in a sub-center level by giving 2 tablets. In case the female is not responding, we have to give the IV injections, not intramuscular. So giving 2 tablets plus IV sucrose is wrong answer because it's not both. 3 tablet is nowhere in the program. IV iron sucrose, if female is not tolerating, this is true answer. IM is not given, this is wrong answer. So which is the best answer I would like to mark? I would like to mark IV iron sucrose to be given in case the female is not responding to the iron folic acid. Coming over to the next MCQ, all of the following are non-contraceptive benefits of OC pills except, so you have to mark the wrong one. This is a very ghisa hua, old time, frequently asked MCQ. Beta, it has been discussed very much in detail in your OBS and Gynae lectures by Dr. Sakshi ma'am. It has been discussed in the family planning module. It has been discussed almost in every lectures. It is there in my textbook also. So there's a very ghisa hua, old MCQ. All are the benefits except reduction in RTI, STI, lower chance of ectopic, risk reduction of ovarian cancer or risk reduction of endometrial cancer. So this is a direct question. There's a direct statement. I have taken this from the conceptual review of PSM textbook, page number 405. What are the beneficial effects of the oral contraceptive pills? So just to inform you, just to tell you that what are the oral contraceptive benefits. Please note that oral contraceptive benefits is that it of course helps in contraception. It also regulates the menstrual flow. That is, it is used in dysfunctional uterine bleeding. It reduces cancer risk, specifically colorectal cancer, endometrial cancer and ovarian cancer. Please note, it decreases the chance of endometrial and ovarian cancer. It also reduces the risk of benign breast disease. I am not saying the malignant breast disease. It has a lower chance of PID. It also decreases the chance of ectopic pregnancies, and there is clinical improvement in the polycystic ovarian syndromes, hirsutism, it decreases the chance of acne and so on. The absolute contraindication have been updated by the Government of India. These can also be asked in your exam. Please note that it is not recommended, very frequently asked in your exam. It is not recommended in breastfeeding females who are within 6 months after delivery. So in lactating females, you cannot give OC pills till 6 months of delivery. In non-lactating females, where the females are not doing breastfeeding, in those cases, you can give OC pills after 3 weeks. So remember, say with me, lactating females after 6 months, non-lactating females after 3 weeks. Remember this. Very important, frequently asked MCQ. Next is, in case a female is smoker, how many cigarettes? 15 cigarettes or 15 BDs per day if the female is smoking, and if the female is more than 35 years, then OC pills are also contraindicated in females with deep vein thrombosis, any heart disease like serious heart disease, bleeding disorders, liver diseases, breast cancers, unexplained vaginal bleeding and so on. I would also like to tell you that it is safe in females. It is safe in females of any age, even over 40 years of age, if they do not have any of the following comorbidities which we have discussed right now. So it is safe in females with anemia also. It is safe in females with irregular menstrual cycles also. This has been commonly asked in your exam. So if you understand all this, which of the following is not a benefit? It decreases the lower chance of ectopic pregnancy. True or false? It is true. It decreases ovarian cancer. True. Decreases endometrial. This is true. It does not have an effect on RTA, STI. So that is a super duper easy MCQ. Direct question, direct answer. Coming over to the next MCQ, the use of hand sanitizer is not recommended in which of the following situations? Before examining the patient, after examining the patient, after touching the beds or surrounding of the patient, and when hands are visibly soiled. This question is appropriate question because of the COVID pandemic and so on. So when should you use hand sanitizer and when to use hand washing? This has been categorically given by the CDC WHO guidelines. They definitely tell you when to use alcohol-based sanitizers and in what situations to use soap and water. If somebody asks you what is better to use, hand sanitizer or soap and water, any day the best answer is soap and water, because so many reactions can happen because of sanitizers. Next point for us to remember is that the hand sanitizer, as per the CDC WHO guideline, it should always be more than 60% alcohol. So hand sanitizers, when to use and when to do soap washing, that is separate, but the point is when to do hand hygiene. So there are 5 situations where we are supposed to do hand hygiene. First is before touching the patient. Second is before doing the procedure. Third is after body fluid exposure risk. Fourth is after touching the patient, and fifth is after touching the surroundings or the patient's surroundings or beddings or whatever. Out of these 5 movements, 2 are critical movements. The 2 critical movements are whenever you are touching the body fluids. So if you are touching the brains or whatever, or we are touching the IV set or the cannula where it enters into the skin, where the skin integrity is broken, these are the critical movements when to do hand hygiene. So hand hygiene, you're supposed to use a hand sanitizer immediately before touching the patient, after performing the task, before, even on the same body. If you are moving from soiled area to the clean area on the same body, again you are supposed to do hand hygiene between that point. And after touching the patient, after contact with body fluids, of course, common sense, this is hand sanitizer. When will you do soap and water touching? When the hands are visibly soiled. Common sense, if the hands are soiled, why would you use hand sanitizer? Also, you are supposed to use soap and water. You are supposed to wash your hands in case we are dealing with highly infectious agents, we are dealing with infectious diarrhea, we are dealing with any disease which can generate spores like the Bacillus anthrax or the Clostridium difficile. In those cases, we are going to do soap and water hand washing. So if you understand this very direct MCQ, घिसा हुआ old time repeat MCQ, the use of hand sanitizer is not recommended when the hands are visibly soiled. That is the best possible correct answer. Let us move to the next MCQ, minimum number of antenatal visits as per the WHO. What else could you ask from God? This is the easiest, super duper easiest MCQ you can ever get. I think most of you must have answered it correctly. Answer is direct MCQ. 8 visits are under the WHO. Beta, please note that under the National Health Mission, how many visits are there? We need 4 minimum visits. The first visit should be as soon as possible within the first trimester. The second visit should be around 4 to 6 months. That is around 14 to 26 weeks. If you get single best answer, mark 26 weeks. Third visit should be around in the 8th month. If you get single best answer, please mark 32 weeks, not 34. Please mark 32 weeks. So it should be around 28 to 32 weeks. And the last visit should be in the 9th month, around 36 weeks till term. Postnatal visits again are 4 visits. First on the first day of delivery, 3rd day, 7th day, and after 6 weeks, that is 42 days of delivery. The WHO care model says total 8 visits. In the first trimester, 1 visit. In the second trimester, 2 visits. In the third trimester, total 5 visits have to be done. This is the WHO 8 care model. So the best answer over here is number of antenatal visits as per WHO. It is 8. Next MCQ. Which of the following options are correct? VVM. What is VVM? VVM stands for the vaccine vial monitor. Vaccine vial monitor. So VVM has a chemical indicator in the circle which changes color. VVM gives an idea for number of days for expiry of the vaccine. It is the only tool among all time temperature indicators that is available at any time in the process of distribution and at the time a vaccine is administered at a health center. It indicates whether the vaccine has been exposed to a combination of excessive heat over time and whether it is likely to be damaged. VVM tells about the efficacy of the vaccine. The expiry date of the vaccine can be relaxed if the VVM is intact. Please note, I'm giving you the disclaimer again. This question is not to replicate any question in the exam, but to help you understand the theme of the question which was asked in the exam. So this question again is a very घिसा हुआ MCQ. Every year you get questions on vaccine vial monitor. So options were like, which of the following are correct? 1, 2, 4, 1, 3, 5, 3, 4, all are correct. What do you want to say? If you talk about vaccine vial monitor, beta, vaccine vial monitor is a chemical indicator. The vaccine vial monitor is outer circle and inside there is a square. Now the square contains the chemical. The chemical is in the square. The circle does not change the color. The square will change the color. So earlier the square is light color. Then it becomes slightly darker if there is more heat exposure. Then there is a same color point where the square becomes the same color as the circle, and ultimately the square will become darker than the circle. So when do you discard the vaccine? Discard the vaccine when the inner square and the outer circle, they become of the same color. That is the discard point for the vaccine vial monitor. So if you look at the questions again, options again, VVM has a chemical indicator in the circle which changes color. This is false. It is not the circle which is changing color. It is the square which changes color. VVM gives an idea for number of days of expiry of the vaccine. VVM does not tell you about the expiry of the vaccine. The expiry of the vaccine will be dependent on the constituents of the vaccine. But during that expiry time, if the vaccine is made for maybe 1 year or 2 years, during that time, if you put the vaccine in, not in the cold chain, what is the temperature in cold chain? 2 to 8 degrees Celsius. So it is from +2 to +8 degrees Celsius. If you do not take care of the heat or the temperature, then the vaccine will get spoiled. So the option number 2 is also false answer. Option 1 is also false. It is the only tool among all time temperature indicator that is available at any time. This is the correct answer because it is available anytime. It is ready to use. Everybody can understand this. The immunizing person can understand. The health workers can understand. It is much easy to understand tool. It indicates option number 4. So option 3 is correct. Option 4, it indicates whether the vaccine has been exposed to a combination of excessive heat over time and whether it is likely to have been damaged. This is absolutely correct. That is what the vaccine vial monitors are made for. So option 3 and option 4, they both are correct. Option number 5, VVM tells about the efficacy of the vaccine. I doubt on this because the efficacy of the vaccine is told by different trials you do depending on the constituents and depending on the type of vaccine that you're using. So efficacy of the vaccine is not dependent on the vaccine vial monitor, right? So VVM is not going to tell about the efficacy. That is wrong answer. The expiry date of the vaccine can be relaxed if the VVM is intact. Very nice. So this is absolutely wrong answer. You can't relax the expiry date of the vaccine. So which is the correct answer? Option number 3 and 4. Only these two are the correct answers. They are supposed to be marked, and option 3 and option 4 are the best possible correct answers. This has been asked multiple times. It has been discussed in your cold chain video number 79. It is there in my textbook also. So everywhere you'll find questions on VVM. VVM is highly important MCQ. This question is from the chapter on health education, health communication. Again, we have discussed this about the health belief model or the health motivation model. So this question was talking about the health belief model. This is the health belief model. In the health belief model, they ask that what is this center stage? What is the center point? So even if you don't know the health belief model, still you can think that what are they asking? So perceive, control, intervention, health motivation, individual behavior. So what is the best possible? This is a direct question from the health belief model, which talks about the health motivation as the center stage. Beta, in the health belief model, there are 3 aspects of this model. One is the perceived susceptibility and the perceived severity. So before you adopt a health promotive behavior or any good lifestyle, you have to be very much convinced that will you ever get that disease? So if a person will ever think that what if I get this disease, that is going to motivate that person. Second is the perceived severity. What if I get the disease and the disease is very severe? So their perception about the disease severity and the susceptibility has to be the first thing that has to be there. The second thing is about the perceived barriers and the benefit. What if I get the disease? That is severity and susceptibility. But to do this lifestyle modification or to do physical exercise or to decrease fat intake, what is the benefit I'm going to get? And what are the barriers? What are the sacrifices that I will have to do? Always, whenever we adopt any healthy behavior, your barriers or your benefits will be more than the barrier. Only then you will be able to adopt that. If ever I say that, beta, you should solve 10 grand tests every week. 10 grand tests every week. Why would you solve that? Unless I tell you that the benefit of solving grand tests will be much more than the barriers that you are going to face by solving the grand test. So benefits should always be more than the barriers. So one is about susceptibility, severity. Second is about the benefits and the barriers. Third is based on the individual characteristic, that is what is the demographic variables like class, gender, age, and the psychological barriers. And last is the most important, that is the cues to action. You should have something available. You should have the grand test, only then you are going to give the grand test. People should be doing yoga and physical exercise, only then you will also do yoga and physical exercise. That is cues to action. So the health belief model is based on the cognitive psychology. This is also one MCQ. It is based on the cognitive psychology of people and has main components as health motivation. It takes the center stage. Other components we have already discussed: perceived susceptibility, severity, perceived benefits, cues to action, and independent variables as the demographic variables. This is what is the health belief model, and the center stage is given by the health motivation. That is the best answer over here. Coming over to the next MCQ, which of the following indicator shows the efficacy of early detection of the leprosy under the National Leprosy Eradication Program? This question is again a Ghisawa MCQ. It's a 5-star MCQ every time in the classes, in the video session, in all the test and discussion modules, everywhere I have talked about leprosy. Two things. One, they'll ask you about diagnosis and treatment, and second, they'll ask you about indicators. Same is true for the National Iodine Deficiency Program also. They'll ask you about the indicators in NIDDCP very frequently. So anyways, coming back to this MCQ, which of the following indicators shows the efficacy of the early detection? Annual new case detection rate per lakh, proportion of MB cases, that is the multibacillary cases among the new cases, proportion of treatment completion rates, proportion of grade 2 disability among the general population. So this has been discussed much in detail in your NLEP module number 55 and Marrow videos. It is also there in textbook of community medicine, conceptual review of community medicine, page 582. So what are the indicators of the NLEP? There are three broad indicators. You have the core indicators, additional epidemiological indicators, and the quality of service indicators. So these you can remember it as service indicators. We can also have core indicators and epidemiological, additional epidemiological indicators. The core indicators are 4. ANCDR, that is annual new case detection rate. Grade 2 disability, G2D stands for the grade 2 disabilities per 10 lakh population. Please note that this denominator is important. Grade 2 disabilities per 10 lakh population, cure rate and prevalence rate. Please remember that prevalence is given as per 10,000 population. ENCDR is taken as per lakh population. Grade 2 disabilities is taken as per 10 lakh population, that is per million population. These are the main core indicators. Out of these main core indicators, which one is called as the impact indicator? The impact indicator is the prevalence rate of leprosy, which is the operational indicator. Operational indicator tells you like, is the program working, yes or no? That is the ANCDR. That is the operational indicator. Operational indicator is also another indicator that is going to tell you how much you are detecting the cases early in stage. That is the number of grade 2 disabilities in general population per 10 lakh population or per million population. This is also an indicator for early diagnosis of leprosy, that is grade 2 disabilities in the general population. That is the program performing nicely, yes or no? So if you understand this, there's a direct MCQ. Proportion of grade 2 disabilities among general population is the best possible answer over here. Next MCQ, this is a funny MCQ from Epidemiology. We have discussed the same MCQ multiple times. The same MCQ had been asked in 2019. It was also asked in 2020 in the INI-CET exam. It has been asked again in 2022 in the INI-CET exam. Question is super duper easy, but only for those who have already learned how to solve this question. Big looking MCQs, but they are super easy MCQs. A study was done to assess the effect of age, gender, residence type, and education on chances of having blindness. The results obtained were shown as below. So people in rural areas were less likely, illiterate people were more likely, elderly people are more likely. Which of the following are correct answers? They had given a toxic looking table like this. So the toxic looking table, I don't know the numbers. I have just made up these numbers. These numbers could vary, of course, common sense, but the interpretation would always remain the same. So they had given about age, gender, education, and residence, and the chance of getting blindness, yes or no. So what do you see over here, beta? Please note that what is this value? P-value. P-value tells you about the significance level. P-value we consider as significant. When do you take as significant? Only if the P-value is less than 0.05. If the P-values are less than 0.05, we take them as significant. What about this odds ratio, 95% CI? What is odds ratio? What do you mean by odds ratio? Please note that the odds ratio, if it is equal to 1, it means no association. If the odds ratio is less than 1, it means a negative association. If it is more than 1, it means a positive association. Right? Everybody understands this? So now if odds ratio comes out to be 2.4, what does this mean? It means that the people in the, listen very carefully, it means that the people in the exposed group are 2.4 times higher risk of developing the disease compared to the normal or non-exposed people. If the odds ratio comes out to be 2.4, it means that this exposed group, it is 2.4 times higher risk of getting the disease compared to the non-exposed. Whenever we talk of this odds ratio, we also find out the 95% confidence interval. Now, in case within that 95% confidence interval, let us say the confidence interval ranges from 1.1 to 3.2. So this 2.4 number, think of it on a number scale. This number will lie within 1.1 to 3.2. Okay. Where is this value 1? The value 1. On a number scale, if I draw, this is the number scale, this is 1. Then you have 1.1, then you have 1.2, 1.3 and so on. And below, you will not have minus, you will have 0.9, 0.8, 0.7 and so on. Then there is like nothing beyond 0, right? So in case, in this example, this odds ratio, confidence interval is 1.1 to 3.2. So where does it lie on a number line? Then on a number line, it is lying somewhere here. Right? This is 1.1 and this number will be 3.2, whatever number. So where is this 2.4? It is lying somewhere in the center. My question is, where is this value 1? This value 1 is beyond, it is not within the confidence interval, it is away. So that means this odds ratio is taken as a significant odds ratio. Please note that if the value 1, if the absolute number 1, value 1 lies within the 95% confidence interval, the odds ratio is taken as non-significant odds ratio. That means it is the risk factor is not conclusive risk factor or a not conclusive protective factor. Whatever it is, it shows no association, non-significant odds ratio. Do you understand this? Now if you look at this table again, look at the odds ratio. So from age, higher age, it shows that higher age is more blindness, 1.4 times risk, 5.4, 13.9 and 54.1. So that means more the age, the more the chance of blindness. Look at the odds ratio, 0.3 to 6.8. Can you see this 0.3 to 6.8? Where does the value lie? 1 lie. It lies within the odds ratio. So this odds ratio is a non-significant odds ratio. It is a non-significant odds ratio. And moreover, you can also see that the p-value is 0.4, that is much higher than 0.05. Then you can see p-value is 0.06, but again the odds ratio is kind of significant, the p-value is non-significant. So this also is not kind of a right answer, but yes, more or less we understand that the p-value in higher ages is more. That means more age you see more blindness. That is one conclusion you get from the age. Second, talking about the gender, male and female. Can you see male? Male is 1, that means no association. Female is 1.5, that is a positive risk that being a female could have more chances. But look at the 95% CI, 0.6 to 4.9. Where does the value lie? 1 lies within the confidence interval. So this also becomes a no association, non-significant association. And p-value also you can see is 0.59. So gender has no association. It is not found to be significantly associated. Gender does not have any association. Coming over to education. Education, you can again say that being illiterate, it has more odds ratio and a more confirmed odds ratio with a p-value also less than 0.05. So that means less educated means more blindness. Less educated means more blindness. And residents, on the same principle, residents, you can see that rural area has 1.13, that is positive association, that is a risk factor, and the odds ratio confidence interval is 1.01 to 4.67. Where does this value lie? 1 lie. It is outside, and the p-value is also 0.048, that is less than 0.05. So it is a significant point. That is, living in a rural areas, it may cause more blindness. So rural area is also linked with blindness. So this is what is the summary of the total game. If you understand this, I have taken this summary and put it into point-wise. Higher chances of blindness with higher age group. This is correct. No statistical difference of the blindness among males or females. There is no gender disparity. Higher education does show a statistically protective effect, or in case other words, I should have put it that illiteracy or lesser education causes more blindness. That is what we are sure of. And there is a statistical difference between the rural and the urban areas. Rural areas more come to be looking as a risk factor. If you understand these points, let's look at the options and you're going to mark the correct one. So people in the rural areas were less likely to develop blindness. This is false. They were more likely to develop blindness. Illiterate people were more likely to develop blindness. This is true. Elderly people are more likely to develop blindness. This is also true. Females are more likely to develop blindness. This is false, because we saw that the gender does not have any disparity. And which of the following are correct? Option number 2 and 3 are correct answers. Another question which was asked in your exam was that if a test has 98% sensitivity and the test comes out to be negative, so it was a reasonably higher test, like 98% sensitivity, and the test comes out to be negative. What does it mean? It needs further evaluation with the test for similar spectrum. Results should be discarded due to false negativity. The test disease has 2% prevalence in the population. Disease can be safely ruled out. What do you think is the best possible answer over here? So all the students who have studied this chapter with me, you already must be knowing that this is the 2x2 table that we can draw. We have the people in the diseased area and we have people in the healthy area, and the test could actually be tested positive or a tested negative. So what do you mean by sensitivity? That is true positive divided by total D plus. What is specificity? That is true negatives divided by the total D minus. That is what is sensitivity specificity. Sensitivity is true positive divided by the D plus. Does it tell you how many people will be D plus? No, it does not tell you how many people will be D plus. So coming to this option that disease has 2% prevalence in the population, this is absolutely incorrect. This is nowhere it comes into the picture. I would also like to tell you that what is this sensitivity and specificity used for? Please remember that sensitivity, it is always used for screening test, whereas the specificity, it is used for diagnostic tests. We also know this point also. The sensitivity, you can remember it is snout. Sensitivity is always to rule out a disease. That means if the sensitive test is negative, that means you can safely rule out the disease, and that is what we mean by screening. What do you mean by a diagnostic test? That is, if the specific test comes out to be positive, you always should be taking in the disease. Specificity is to rule in the disease and sensitivity is to rule out the disease. You can remember it as spin and snout. So based on this, if you understand this question was asked, if a test has high sensitivity and the test comes out to be negative, what are you going to do? You already know that sensitivity is to rule out the disease. So the best possible answer is disease can be safely ruled out. That is option number D is the correct answer. Another question which was asked in this session was about blindness and visual impairment. Most common cause of moderate to severe. Point to be noted, it is moderate to severe visual impairment. They did not ask about blindness. Most common cause of visual impairment, moderate to severe visual impairment in age group less than 50 years, young age group, not more than 50 years. So there were 3 points you had to learn. Like they are talking about cause of visual impairment, not blindness. cause of moderate to severe visual impairment, and age less than 49 years as per the NPCB 2019 survey. When I started teaching this 2019 survey in the classes or in the video sessions, many students told that, sir, this is not correct because NPCB survey, nobody is going to ask you. And there you are in 2022, you get a direct question from this. This survey was conducted across India in 2015, from 2015 till 2019. This question is directly taken from the survey summary report. Point number 1 for you to note is that the definition of blindness had been changed as per the NPCB survey report. The blindness, we had a cutoff of less than 3/60 in the better eye with available correction, not with the best possible correction. So that is point number 1 for you to note. Next was that the visual impairment had been categorized as visual impairment is less than 6/18 in the better eye with available correction. Now the visual impairment could be moderate, early visual impairment, moderate visual impairment, or we can have the severe visual impairment. In these visual impairments, different classes were there. So now we do not use, and this NPCB survey did not use social blindness, economic blindness, absolute blindness, manifest blindness. These terms were not used. Rather, we use the severe visual impairment, moderate severe visual impairment, early visual impairment, and so on. Next, there was a new definition, new category of people, that is the functional low vision. So these were important points for you to note, that how to categorize blindness, visual impairment, and functional low vision as per the NPCB 2019 survey. So very important. Second was they gave you different pie charts regarding the most common cause of blindness and visual impairment. So they divided the NPCB people, they divided the NPCB program, they divided the population into age less than 50, young population, and age more than 50. So they told you the cause of blindness cause, figure number 6, this direct screenshot from the NPCB survey. Figure number 6 tells you about the cause of blindness, age more than 50 years, and cause of visual impairment, age more than 50 years. Then you also had cause of blindness age 0 to 50 years and cause of visual impairment age 0 to 50 years. So I have made a summary table out of this. Of course, pie charts, you can always look at the screen and take a screenshot. But this is just the summary table, age less than 49 years and age more than 50 years. Causes of visual impairment. So age less than 49 years, please note that the cause of visual impairment was refractive errors and not untreated cataract or anything else. It was not glaucoma. Refractive errors was most commonly responsible for visual impairment age less than 49. And first was refractive errors, and then was cataract and globe abnormalities and non-trachomatous cornealopathies and so on. Age more than 50, answer is always cataract. So visual impairment causes cataract. Blindness causes cataract. Cataract is a very important cause of visual impairment and blindness in age more than 50. Age less than 50. Visual impairment, it is refractive errors. Say with me, age less than 50, it is refractive errors, and age more than 50, it is cataract. Age less than 50, visual impairment is refractive errors, whereas age less than 50, blindness causes non-trachomatous corneal opacities. So these were the most common cause of visual impairment and blindness. So obviously you can see in this MCQ, they asked you that in young age group, what is the most common cause of visual impairment? It is refractive errors. You're going to mark refractive errors as the best possible answer. Coming over to the questions from session number 2, kind of questions which were asked in session number 2. Very easy, super duper MCQ. What are the concepts, or what are the definition in concepts of community medicine? Match the column A with column B. Pre-pathogenesis, early pathogenesis, clinical horizons, convalescence phase, and disability limitation. So you had this column B. So what do you want to match this with? If you look at this question was directly made from this textbook of part, page 42, edition 26. They gave this photo, they gave this image, they gave this picture about the stages of pre-pathogenesis and pathogenesis, and what is this clinical horizon and so on. So if you look at this question, in the pre-pathogenesis phase, there is agent, host, and environment. That is what is the pre-pathogenesis. That is, the infectious agent is there, the host is there, and environmental phase is there, and the pathogenesis has not started because the infectious agent has not yet entered into the human body or any body. So after this, there is onset of pathogenesis when the agent will enter into the person. So once the agent enters into the person, there is clinical horizon, that is onset of clinical symptoms and so on. So if you understand this, let us take a peek into what are the concepts. Pre-pathogenesis phase, it is with epidemiological triad. Right? That is what is the pre-pathogenesis phase. In the early pathogenesis, what do we mean by this? In the early pathogenesis, we actually are looking at the person may not show sign and symptom. They are in very early phase. So entry of the organism till the first sign and symptom. What is this known as? This concept is called as the incubation period. So option B would go with the incubation period, that is the early pathogenesis. Then you have the clinical horizon. Clinical horizon means the onset of the clinical features. Clinical horizon means onset of the clinical features, that is sign and symptoms. What do you mean by convalescence phase? Convalescence phase, beta, it is the phase which happens after recovery. This recovery phase is called as the convalescence phase. Okay, so recovery phase is called as the convalescence phase. That is the option A, that is the follow through the treatment towards the recovery. Recovery phase is the convalescence phase. What do you mean by disability limitation? Disability limitation, how will you limit the disabilities? That is by giving them rehabilitation. So now I think you can very well match the following. So A goes with which one? A goes with C. So I think in the options we have just named as 1, 2, 3, 4 and 5. So A goes with 3 and B goes with 5. C goes with 4 and D goes with 1 and E goes with 2. E goes with 2. So which is the best answer over here? I think option number B, A3, B5, C4, D1, E2. That is the best possible correct answer in this question. Coming to another simple MCQ, what else you could ask God from? You might be thinking you're scared of biostats and so on, and there you get such a super duper easy MCQ. The following formula represents what? Standard error, standard deviation, variance or coefficient of variation. This has been discussed much in detail. How to make this formula, how to derive this formula, I've discussed with you in the chapter on measures of variation in the video module on measures of variation, module number 16 in your Marrow video community medicine application. So the following formula represents, please remember this is the answer. I think everybody must have got this right. This is the formula for standard deviation. What is standard deviation? Standard deviation is root mean square deviation. Root of mean of squared deviations. So it is root of, root means square root. That is what is this? Root of mean. Mean means summation divided by the sample size. Of squared deviation. Squared deviation is what is this? So this is a simple formula. Remember RMSD, root mean square deviation. Why do we do n-1? This is a correction that you apply in case of small sample. In case of small sample, we do n-1. In normal samples, we simply take n. So n-1, you use it as standard deviation in small sample. This is the best possible answer over here. Next MCQ, which of the following is the best indicator for efficiency of the contraceptive? Pearl's index, Sullivan index, abortion rates or performance index. Super duper MCQ. I don't need to explain this question also. Which of the following indicator is the best indicator for efficiency? Answer is Pearl's index. What do you mean by Pearl's index? Pearl's index gives you the failure rate per 100 women years. It is given by the formula number of accidental pregnancies divided by the total women years of exposure into 100. In case the MCQ says women months of exposure, in those cases you multiply by 1200. Otherwise, if the question says number of women years, you multiply it by 100. That is what is the Pearl's index. Sullivan index, it is a positive indicator. It tells you about the life expectancy minus DALY. It tells you how many number of years lived free from disability. It is number of years we are going to live free from disability, not with disability. That is what is Sullivan index. Abortion rate and performance index. We calculate the abortion rates, but there's nothing called as performance index. The next MCQ is again super duper easy MCQ. The water is collected from a broken septic tank and the larva breed was obtained. Identify the breed of the mosquito. Aedes mosquito, Culex mosquito, Anopheles mensonia. This is a super easy MCQ. We have discussed this multiple times in the section on video section on entomology, video number 91 in your Marrow Community Medicine lectures. So this is like different types of mosquitoes, Anopheles, Aedes, Culex mensonia. Please note that the Anopheles mosquito lives in which water? It lives in clean stagnant water. It breeds in clean stagnant water. The Aedes mosquito, it breeds in artificial stored water. Culex is in dirty polluted water, which is polluted with sewage. It could be polluted with any pollutions. It could be fecal contaminated. Any Culex is in dirty polluted water. Mensonia is in large water body with aquatic vegetation, that is lakes and ponds and so on. So even if you don't know anything about the larva, still even if you know some things about Culex is in dirty polluted water, answer is Culex mosquito. So please remember that this looks like Culex mosquito. Culex mosquito, a larva has a long siphon. Culex has a long siphon. The eggs are in clusters and in rafts. The larva has a long siphon. It is a bottom feeder and has a siphon tube to breathe. Whereas the Anopheles, it is a surface feeder. It is just near the surface, at the surface of water, and it does not have siphon. So please remember that this is the siphon and this is what is a Culex mosquito. Best answer over here is Culex mosquito. Post-earthquake, some buildings were destroyed and the building codes were changed to make the earthquake more resilient or resistant buildings. This is known as what? Disaster response, impact, mitigation, or preparedness. So what do you think you're going to mark? Please note that in the disaster management cycle, whenever there is a disaster, then there is emergency response. Emergency response is the response which happens within 6 hours. This is the most important or the crucial phase, of disaster response. And then there is rehabilitation, reconstruction, vulnerability assessment, preparedness. And then there is also, like this all is together, planning and policies, doing planning and policies and legal route to decrease impact of disaster. This is what is called as disaster mitigation. This is what is called as mitigation, that is disaster mitigation. That is, you anticipate that how the disaster should be, and because based on the understanding of the disaster, you plan your things much in advance. This is what is disaster mitigation. It is rules, regulations and legislations which help in planning and make safer areas. The prime objective is to reduce the impact of the disaster using better planning and organized systems. These are what are mitigation system, and that is what is disaster mitigation. So best answer over here is option number C, that is disaster mitigation. The next MCQ was regarding the Hooch tragedy. It is related to methyl alcohol, ethyl alcohol, propanol or ethanol. I don't know how many of you know about hooch, yes or no. But hooch is just it's a slang word. It's a new word you can say, which we give it for country-made liquor or the desi liquor or the desi daru. So country-made, locally made alcohol, which is locally made, and therefore there is no quality control, there is no standardization. They are exempted from tax also because there's no one knows that it's being made. And these are being sold in the market. It is country alcohol which is adulterated with industrialized level alcohol or the methanol. Methanol is what was asked in your question, which increase the intoxicating potency of hooch or the locally made alcohol. It is rampant in the state of Madhya Pradesh, Karnataka, Bihar, Chhattisgarh, UP, Punjab and Gujarat. We also had a big time hooch tragedy from Gujarat. States, these 5 states, Mizoram, Gujarat, Bihar, Nagaland and Lakshadweep, these are now, they are banned from any type of liquor sale in these states. Earlier we had this hooch tragedy from Gujarat also, Karnataka, Bihar, Chhattisgarh and UP. So direct question, direct answer is methyl alcohol or methanol, that is related to hooch tragedy. Match the following with the scientist's contribution. I don't know where to put this question, whether it is from history of community medicine or from epidemiology. But anyways, these are simple questions which I think that you should be knowing. Edward Jenner, he was one of a very passionate person who was passionate about science, and he looked at very keenly for the observations, and he was the first person to give the smallpox vaccine. So Edward Jenner is known for smallpox vaccine. James Lind was a sailor. I've discussed this in the Marrow lectures also. I told the whole story about James Lind. James Lind was a naval surgeon, and he divided people into people taking oranges, people taking other fruits, people taking other things. And then he saw that people who took oranges or vitamin C, they developed less bleeding gums and they did not die from scurvy. So James Lind was known for scurvy. Waller Reed was known to discover the yellow fever vaccine. So A goes with 3, A goes with 3, B goes with 1, and C goes with 2. That is what is the best possible optimized answer over here. A3, B1 and C2. It's a simple question, simple answer. Which of the following is incorrect for the vaccine vial monitor? Another question on vaccine vial monitor. Use if the inner square is lighter than the outer circle. Use if the inner square is lighter. So discard if the inner square starts changing color but is lighter than the outer circle. Discard when inner square and outer circle are of same color. Discard if the inner square is darker in color. We have already discussed about this in the same session, that the vaccine vial monitor looks something like this. You have the inner square which is light in color, and then there is a point D which is the same color, and this is also called as the discard point. So it has been discussed in your Marrow videos and in your Marrow notes also. This is a simple MCQ. So which of the following is incorrect? You have to mark the incorrect one. Discard if inner square starts changing color but is lighter than the outer circle. You do not discard that. You in fact use that vaccine. So this is incorrect answer. This is the option number B, which is the best possible answer over here. Coming to the next MCQ, under NVBDCP National Vector-Borne Disease Control Program, the co-formulation artemether plus lumefantrine given below is available in the fixed dose combination of, what do you think you're going to mark? 25, 12.5, 120, 200, 20 milligram and 120, 120 and 20. So this ACTAL, what is this ACTAL beta? It is nothing but a fixed dose combination of artemether plus lumefantrine. In what situations do we give ACTAL? It is given in case of Plasmodium falciparum infections in northeastern states. So only in those 7 sister states in the northeastern states, Government of India, for falciparum infection, we give artemether plus lumefantrine combination. These artemether lumefantrine combination, they are available in 4 color categories. That is the yellow color, green color, red color and white color. So this also has been given in your Marrow notes, in malaria treatment, in video number 48, that there are these yellow category, green, red and white category. So it is given, yellow category is given to age more than 5 months. It's not less than 5 months. It is age more than 5 months to 3 years. 1 tablet we are giving of artemether plus 1 tablet of lumefantrine. Artemether in dose of 20 milligram and lumefantrine is given in the dose of 120 milligram. So each tablet, it contains 20 plus 120 of artemether plus lumefantrine. That is what is the ACTAL. So what is the best answer you're going to mark? It is 20 milligram of artemether plus 120 milligrams of lumefantrine. Coming over to the next MCQ, the following chart represents. So this question is relatively, I would say, a new question. And sometimes INI-CET does talk about these type of out of syllabus questions, but anyways, nothing called as syllabus. There's a PG entrance exam and a prestigious INI-CET exam. They're bound to ask questions, googly questions like these. So what does this chart represent? Does it represent Gantt chart, PERT chart, component causal chart or epidemiological pie chart? So anyways, this answer is not a Gantt chart. Gantt chart are time schedule charts. These are time schedule charts, where you schedule your activity, that I will do this activity for this much time, this much time, this much time. This is January, February, March. I will do PSM and medicine and pediatrics and gynae in January. Then in February, I'll do this. In March, I'll do this and I'll do this. Whatever you want to say. These are time schedule chart. These are called as Gantt chart. What are PERT charts? PERT stands for Program Evaluation and Review Technique. PERT charts are arrow diagrams. They are basically for sequence of events. I will do anatomy. After anatomy, I will do surgery. After surgery, I will do ortho. And then after surgery and ortho, after completing everything, then I'll switch over to IE and ENT or things like this, whatever you want to say. So this is a sequence of events that you have planned. That is what is per chart. So none of them looks like the circles given. It could be a component causal chart. It could be epidemiological pie chart. In fact, they both are almost synonyms, but there's nothing technically we don't call epidemiological pie charts. So by virtue of exclusion, I would say that this is component causal chart. Just by virtue of exclusion, these are causal charts because they don't look like Gantt charts. They don't look like PERT charts, but there's nothing called as epidemiological pie charts. So these are component causal charts. So what are component causal charts? These were given by Dr. Rothman. Rothman's Epidemiology contains this topic of component causal charts. It says that for any disease to happen, any event to happen, there are components for that disease. Something like you can relate like attributable risk. So there are components for that disease. Now that component could be a necessary component or it could be a sufficient component. Necessary means that that component should be there in every person, in every individual who gets that disease. That is a necessary component. Sufficient means that sometimes that two variables could be sufficient. Let me take a very simple example. What are the ingredients for success or clearing entrance exam or clearing screening exam where you just want to take 50%? So what are the ingredients? What do you think are the ingredients? Hard work, smart work, doing question banks, videos, watching videos, group discussion with your friends, notes, making your own handwritten notes and written notes, self-assessment, GTs, SWTs, social media discussion, motivations and family support, mom, darling, sibling and dash, dash, dash. I hope you understand girlfriend, boyfriend and all that. So what are the ingredients of clearing the exam? What do you think? Does it require everybody to have everything together? These are different components. Out of these, which are the necessary components, which have to be there? You can't afford to clear entrance exam without that. So necessary component, according to me, I would say that is a video and a Q bank and self-assessment. These have to be there. Even if you have good family support, your mom, dad, your girlfriend, boyfriend saying that, Shabash, take on, still you don't do Q bank, how will you clear the exam? So these are necessary components. That is the Q bank. You have to solve them. Videos, you cannot clear an entrance exam without videos or without Q bank. They have to be there. And you have to self-assess. These are the most important things for clearing. So I would term these as necessary components. Now making this whole example into a medical example which you think you would be able to understand. When will a person get HIV? When will a person get HIV? When there is exposure to HIV? Definitely yes. High risk sexual behavior if they do and absence of ART. Out of these are main three components. Out of these, which is the necessary component? That has to be exposure to HIV. There have to be sexual behavior and absence. These are like not necessary, but they are sufficient causes. They may cause HIV. Do you understand this? What is HIV? So in this, I would say that this has to be there. It has to be there in any person who gets HIV. Similarly for tuberculosis, let us say a person has HIV, a person gets malnutrition and a person gets exposure to TB, which is the most necessary cause. Necessary has to be exposure to TB, right? But HIV and malnutrition are sufficient causes to cause TB. On the same principle, if you look at overcrowding, you replace HIV with overcrowding, you replace malnutrition stays and exposure stays. So exposure is like a common thing in getting tuberculosis. That is the necessary component. This becomes the necessary component, that is exposure to tuberculosis. Exposure to TB has to be there whenever the TB is there in a patient. So that is what is this component causal charts, and that is what this denotes, that this red color thing you can see is common in all the charts. The red or the orange color thing, whatever you see on the screen, that is common in all the charts. That is what is a component causal chart. This was a new topic, new MCQ asked in INI-CET exam this year. Next MCQ, a relatively familiar MCQ, Gisawa MCQ, old MCQ. The individual reports with large wound from a dog bite. It's a large wound and from a dog bite which is bleeding. Consider the following options: anti-rabies vaccine, intramuscular, 037-14-28. Clean the wound for 10 to 15 minutes. 2 doses of equine rabies immunoglobulin given at the dose of 40 international units per kg. Body weight, do immediate proper wound suturing. Cover the wound with sterile dressing. Which of the following statement are correct? 1, 2, 3, 1, 2, 4 and so on. So whenever we are talking of anti-rabies vaccine or rabies, this is a very favorite topic asked in your exam. It has been discussed in zoonosis and rabies video module number 36 in your marrow application. So animal bites, they can be classified into class 1, class 2 and class 3. Class 1 are simple licks and touches on intact skin. Class 2 is minor abrasion. Class 3 is major wounds. So that is what this question was. There was a major wound. And also I would like to caution you in your exam, there can be licks, mucosal licks by wild animals on mucosal surface is never categorized as category 1, it is category 3. Category 3 is mucosal licks by wild animals, deep tissue injury, deep tissue loss. In these cases, we give wound management plus ARV plus rabies immunoglobulin. So what is the rabies immunoglobulin? Rabies immunoglobulin can be given as equine or human. Human given at the rate of 20, equine given at the rate of 40. So in case of dog bite with blood oozing, we are going to give all three, that is vaccine plus immunoglobulin plus wound management. Please note that we never do immediate tight suturing. The sutures should always be loose. They should be delayed sutures. Sutures should be made after 24 hours. Because you don't want to interfere with a lot of nerve endings and you don't want to touch around the wound so much. Also, MCQ on rabies immunoglobulin should be infiltrated in the wound. Maximum amount of immunoglobulin should be infiltrated in the wound. Of course, make sure that you do not cause compartment syndrome, that you put so much rabies immunoglobulin inside the wound that you cause edema and compartment syndrome over that. So you put adequate amount in or around the wound, and remaining you give in the nearest intramuscular site. As far as the post-exposure prophylaxis are concerned, we have two major post-exposure prophylaxis, thigh regime and the SN regime. Thigh is what is the intradermal regime. There are 4 visits. And on each visits, there are 2 doses, 2 vaccines, 2 sites to be taken, 8 doses to be given in total. 2 doses per visit. So 4 visits, 8 sites. SN regime is what is intramuscular regime, 5 visits, and there are 5 doses of the vaccine. So if you understand this is simple MCQ, which of the following is correct? Will you give anti-rabies vaccine intramuscular on 0, 3, 7, 14, 28? This is true. We can give SN regime. Clean the wound for 10 to 15 minutes with soap and water. Yes, this is correct. It is recommended to not decrease the time like less than 15 minutes. It should be average time of 10 to 15 minutes and not more than 20 minutes, because you do vigorous washing over there then. 2 doses of equine rabies immunoglobulin at the rate of 40. This is also true. Do proper wound suturing. Oh, this is wrong. And cover the wound with tight dressing. This is also false. So which of the following is correct? 1, 2 and 3 are correct answer over here. Let's move to the next MCQ, snake bite management. So this was a question which was discussed a few days before the INI-CET exam. Snake bite management includes loose tourniquet, debride to avoid spread, identify and kill the snake, reach hospital, or there should be immobilization. Which of the following is correct? What do you think you're going to do? So will you put a tourniquet over there? So please note that in snake management, the mnemonic is carry no right. Remember this, carry no right. Carry means do not allow the victim to walk. That is the first thing. First is carry. So you do not allow the victim to walk. Usually the snake bite would be on the lower limbs. It could be on the hands also. But we do not allow the victim to walk in any type, in any form, especially when the bite is in the legs. So you always help them to carry, because you don't want to have too much venous flow over there. There is no, big time no. No for what? Carry no. No means so many no's. No means there should not be any pressure bandage on the area. No tourniquets, no pressure immobilization, no debridement, no herbs, no traditional medicines, and no finding the snake and killing the snake, because you lose the time. Adding traditional medicines, they actually harm the area. Debridement, immobilization, it does not help. It actually causes more damage to the area rather than helping it out. So it's a big time no. Then no tourniquet, no electrotherapy, no cutting, no pressure immobilization. We have to reassure the patient. Immobilize the patient as the same way as a fractured limb. Please note, we do not apply compression bandages. It only needs a splint and a small cloth to hold the splint. That's all. You do not block the blood supply. This is very important. It should be written in bold letters. You never block the blood supply. Get to the hospital immediately. Don't waste time in finding the snake, cutting the snake, cooking the snake, and tell the doctor that what was there, that what are the symptoms. That's all that is required. Most of the 50 to 70% of the bites are non-venomous bites. So what is the best answer over here? Will you apply tourniquet? No. Debride? No. Identify? No. Reach hospital? Yes. Immobilize? Yes. So which of the following are correct? 4 and number 5 are correct answers. Coming over to the next MCQ, which of the following criteria should be satisfied to start MDT? What is MDT? MDT stands for multi-drug therapy. Where do you give MDT? MDT is given in cases of leprosy, multi-drug therapy. More than 5 hypopigmented patches, hypopigmented patch with the sensory loss, peripheral nerve thickening with sensory loss, skin biopsy demonstrating bacilli. So in what situations will you start MDT? Very simple question asking about leprosy. Leprosy has been talk of the INI-CET exam. It can again be asked in your NEET exam, FMG exam, wherever, whatever exam you're giving. Leprosy, I don't know, somehow it has been talk of the town. So how do you diagnose leprosy, beta? There are 3 cardinal signs. Out of this, any one to be present, that is called as leprosy. It is hypopigmented patch or reddish lesions with, please note the word is with, hypopigmented patch or reddish lesion with sensory deficit. So sensory deficit has to be there with the patch, hypopigmented patch. Involvement of peripheral nerves, identify the word with, involvement of the nerves with a definite thickening, with loss of sensation, with weakness and paralysis of the corresponding muscle. That is what is the nerve involvement. And third is demonstration of the Mycobacterium leprae in the lesions. So out of these three are called as cardinal signs. Please note, hypopigmented patch with sensory loss and nerves with the thickening, with sensory loss, with weakness or paralysis. That is what is called as nerve involvement. So based on the nerve involvement, which is the most common nerve to be involved, it is the ulnar nerve. We can see reddish patch or we can see hypopigmented patch, but there should be sensory involvement also. There should be loss of the sensation also. So this is what is categorized as leprosy. Next time, they can also ask you about disabilities in leprosy. Disability can be graded as grade 0, 1 and 2. So in case of limbs, that is hands and feet, no anesthesia over palm and soles, no visible deformity is grade 0. Anesthesia present but no visible deformity, where you cannot see. Visible, it's not there, but you can feel. If feeling is there, that is grade 1. But in case the visibility is there and the feeling is definitely there, that is called as grade 2. In eyes, it is grade 0 where there is no eye problem, or grade 2 there is severe visual impairment. So please note that's how you categorize the disabilities in leprosy, and that these are the cardinal signs. So now if you understand this, let us have a look at the MCQ. Which of the following criteria should be satisfied to start MDT? That is very simple to understand. Is like, when do you diagnose leprosy? More than 5 hypopigmented patches. No, that is not correct. It is more than 5 hypopigmented patches with the sensory loss. So this is kind of correct, option number 1, but it is incomplete. Which is better answer? Hypopigmented patch with sensory loss. Option number 2, that is correct answer. Third point is peripheral nerve thickening. No, this is also not correct because it is incomplete. Peripheral nerve thickening with the sensory loss, with weakness or paralysis in the affected area, that is the correct answer. Option 3 is not correct. Option 4 is also incomplete. Option 5, skin biopsy demonstrating bacilli. Is this correct? Yes, this is correct. So there are 2 correct answers in this statement, that is hypopigmented patches, or it could be reddish patches with sensory loss, and skin biopsy demonstrating bacilli. These are the 2 cardinal features. So I would like to mark option 2 and 5 as the correct answer. 4 could have been correct if there was with muscle weakness also. But in this MCQ, option number C, 2 and 5 are the correct answers. So moving over to some of the overlapping questions from different subjects and different sessions asked in the INI-CET exam. So very quick review, just telling you about the best possible right answer. Long-acting reversible contraceptives, that is the LARC contraceptives. Please note that LARC, long-acting reversible contraceptives, these are 2, that is intrauterine devices, or we can have implants. These are applicable for many years. Once you put them, you can use them for many years, and that's the reason these are called as long acting, and they are reversible. That is, there is return of fertility. In Government of India, we are using 2 intrauterine devices, copper T380A, and we are also using copper 375 device. Copper 375 device is valid for 3 to 5 years. Copper T380A is valid for 10 years. And the best possible answer is implants and IUCD in this case. Next is a patient presents with black HR on the back with chills and rigors and high-grade fever. The probable cause over here is, so the keyword over here is black HR. I think everybody knows. It is a categorical, it is a pathognomonic feature. It is a very prominent cardinal feature of scrub typhus. So this has been discussed in the rickettsia module, video number 38 in your Marrow Community Medicine lectures. Scrub typhus, it comes with rash on 5th to 7th day of fever with black spot near the bite of the mite, that is the ishar, and there is generalized lymphadenopathy. The investigation of choice is wheel-Felix reaction. Treatment is with doxycycline or tetracycline. That is what is the scrub typhus. So black ishar should be scrub typhus. So the next MCQ was image-based MCQ. Which of the following virus is related to shifts and drifts? So you can see that all were viruses. A and B, they look quite similar. A, but if I don't know if you can appreciate within the screen that A has a surface protein that is the GP120, and inside there is RNA nucleocapsid. So it looks like they are talking about the HIV virus. Option B, if you see, it has hemagglutinin, that is HA, and it has neuraminidase, that is, we are talking of the influenza virus. Option C, you can see that it has a large protein RNA nucleocapsid, and it is a bullet-shaped virus. They are talking of the rabies virus. Option D, you can see it is a Shepherd-Cook type of filamentous virus. This is Ebola virus. So question was very straightforward. Shifts and drifts is related to what? Shifts and drifts are better related to the influenza virus. In influenza, you already know that there are 2 surface protein. You have the hemagglutinin and the neuraminidase. When the virus attaches to the host cell, then there is hemagglutinin, that is the surface protein, which activates and it initiates the infection, and then there is neuraminidase, which helps in release of virus particles, and it helps in infectivity of the other cells. And neuraminidase and hemagglutinin, they both are responsible for the pathogenic potential of the influenza virus. The influenza virus, the hemagglutinin, that is the HA, there are many types. There are 18 HA types and there are 11 NA neuraminidase types. Out of these, the first 3 types of the HA, H1, H2 and H3, are known to cause human diseases. Neuraminidase N1 and N2 are related to human diseases. You can have various combination of these hemagglutinin and neuraminidase type of influenza viruses. As far as the antigenic shift and drift is concerned, shift is sudden change. Shift is sudden change and it is a major mutation. It is a major mutation, and this may cause epidemics or pandemics, whereas drifts, these are slow drifts. These are gradual changes. These are gradual changes and they are related to point mutations in the HA and the NA proteins of the virus. So this is about the influenza virus. Next is, which of the following statement is incorrect? So what is not correct? Which is incorrect? Phase 1 pharmacokinetic studies. Phase 4 is post-marketing surveillance. Phase 3 is 5 to 10 patients are taken, and phase 2 is to study pharmacoepidemiology. So which is incorrect? It's a super easy MCQ. Clinical trials. How many types of clinical trials? We know there are 4 phases of clinical trial. Phase 1, 2, 3 and 4. The phase 0 and the phase 5, these are like not very mandatory, but they should be conducted. But there are 4 basic types of clinical trials. We'll talk about the phase 0 and phase 5 later on. Let's talk about the phase 1, 2 and 3 and 4. So in phase 1, we are taking healthy volunteers. These are healthy subjects. They are not diseased people. So this, we do it to study the pharmacology or the toxicity or the maximum tolerable dose. Phase 2 is done in few hundreds of patients. I've remembered it as few tens. 1 is tens, 2 is hundreds, 3 is thousands. That's all that I have remembered. Tens, hundreds and thousands. So tens is in case of phase 1, thousands and hundreds in case of phase 2 and thousands in case of phase 3. In phase 3 we take patients, and in phase 2 we take patients, but in phase 1 we take healthy volunteers. After phase 3 the drug is being given to the FDA for approval or the CDSCO for approval, and after approval we do post-marketing surveillance, that is the phase 4 trials. In phase 4 trials, we study the long-term effects of the drug reactions. Now, after these phase 4s, when a drug is there for a very long time, like pioglitazone, rosiglitazone, atorvastatin, there have been drugs like metformin, they have been drugs since ages. So they are being used in the communities. Now you do very long-term pharmacoepidemiological studies to confirm any rare side effects, to confirm any severe or unknown adverse drug reactions. These are called as pharmacoepidemiological studies. These are very long term, usually conducted over decades. They don't conduct over 1 year, 2 year, 5 year. They're conducted over 10 year, 20 year, 30 year studies. And these are pharmacoepidemiological studies. These are phase 5 studies. So which is incorrect? Incorrect studies is not phase 2 is you don't do pharmacoepidemiology, which is the best wrong answer. Phase 2 is not done for pharmacoepidemiology. Phase 2 is done on few hundreds of patients to find out the dosage and to find out the efficacy and the dose of the drug. And so with that, thank you so much for watching this module about Community Medicine INI-CET 2022 Recall MCQs.